Hello, good evening. Can you all hear me at the back? Excellent, that's a good start, isn't it? Hello, good evening. My name is Peter Brindle. I'm a GP in Bristol. Welcome to this evening's People's Choice event here at the M Shed. Thank you very much for coming along this evening. This is all part of the Bristol Health Partners Bristol Live event that we've had today, and this evening's event is done in conjunction with the Festival of Ideas. Today has really been about launching Bristol Health Partners. Bristol Health Partners is a collaboration of the two universities in Bristol, the local health trusts, and the City Council. And its central purpose, is really to transform the prevention and treatment of health conditions within Bristol. Today, as I said, we've been launching the TEDMED event, and we've also been hooking up with the TEDMEDLive that's taking place in Washington, D.C., because that's where TEDMED started. So we've been very lucky to be part of their setup today and at least listen to one or two of their talks and share some of their thoughts about common health and major health problems. The whole daytime event has been filmed and is going to be up on the Bristol Health Partners website quite soon. And in fact, this evening's event is also going to be filmed and put on the same website at some time. To help set the topics for the day's events, one of the things we did was work in conjunction with the local Bristol newspaper, The Post. And through them, we asked the public what they thought were the major health challenges facing Bristol at the moment. And the number one voted health challenge was dementia. So that's why we had a session dedicated to dementia earlier on this afternoon, and that's why we're having this People's Choice event this evening. Before we get started, a few routine housekeeping points. First of all, we're going to be doing a survey, an email survey, because really your views are incredibly important to us. We want to be able to make events like this get better and better each time we have them. So once the evening's over the next day or so, you will be receiving a survey by email, and it'd be really great if you can fill it in. Part of that survey, you will be asked if you'd like to contribute some of your contact details so that we can keep in touch over time. If you can do that, that'd be brilliant. As usual, please turn off your mobile phones or pop them to silent. I'm not sure if we've got any active tweeting at the moment, but carry on to tweet if that's what you want to do, but it's not projected up at the moment. As I said, we're filming the event tonight, and it will be available on the website shortly. We will be finishing at the latest at 7:45. We may finish earlier, depending on how things go. If, for any reason, you need to slip away, that's absolutely fine, but try and do it as quietly as you can. But we'll definitely be out of here at 7:45. Although you can see a whole panel of people in front of you here today, this evening's event is really about hearing your thoughts, your views, and your comments, you, the audience. That's what's going to make it fun and interactive. And although I'm standing here and these guys are sitting around here, it's going to be an informal event, so we just want to keep it as interactive as possible. This isn't a time when we just listen to lots of talks and go away the wiser. This is all about hearing what you think about this really important topic around dementia screening. Do people really want an early diagnosis? So please enter your ideas and speak up. We're going to have a couple of roving mics as we did earlier on in the day. So try and wait until the mic reaches you, because unfortunately the acoustics are not great, and without the mic you just won't be heard very well. There are loads of us here. Lots of us will want to say something as the evening goes through, so do try and keep your contributions succinct so that we can get as many views in as possible. We're going to introduce the panel in a moment, but I think it's just worth reflecting on really why we're here and why we've got such a full house this evening. And in fact, we were well oversubscribed in terms of people who wanted to come along this evening. I'm sure it's true to say that there's not a single person in this room who hasn't been or will be affected by dementia in some way over the course of their life. Either, sadly, themselves being affected by the condition, or through a friend or relative who's suffering from dementia. I think it really is something that does touch all of us, and increasingly so. And in fact, I think I read something yesterday that surveys say that, that dementia is the #1 health concern amongst people over 55. So I think we'll be seeing plenty more of these sorts of events and more discussion around this important subject. So within Bristol, we've got, I think, about just over 4,000 people that probably have dementia, but only about 2,200 of those actually have a diagnosis of dementia. So can we do better than that? Should we do better than that? Is more diagnosing necessarily a really good thing? And that's what we're going to be discussing tonight with your help. To help us get along, get the ball rolling, we've got a fantastic panel here, which I'll be introducing. We're really lucky that they've been able to join us, and between them, they've got a great wealth of expertise and experience. In no particular order, let's start with Rick down the end. Rick recently deserted the cold face of NHS work as a psychologist for an ivory tower in the University of West of England. I hope it's comfortable for you, Rick. And over here we've got Chris. Chris used to be, well, in fact, he was the RAF, can you believe this, the RAF's first and last psychogeriatrician. Amazing. You would never think that the RAF would have great scope for psychogeriatricians. Actually, clearly they don't, because they never got another one. But since then, Chris has he's worked for about 11 years as an NHS consultant, and then managed to research his way into another career as a researcher at the University of West of England. Richard Gray at the end. Richard Gray is pretty new to Bristol. He's a mental health nurse by training. Recently moved to Bristol from Norwich, where he tells me there are a lot less hills than there are in Bristol. That's quite an observation there, Richard. Making such great observations has managed to get him a post at the University of West of England, where he is a professor of mental health nursing. And I'm sure he'll be coming up with even more and better observations than that. Derek down here on my left. Derek is a carer. His wife has had dementia for about 25 years. And Derek, he does really like the suggestion that drinking red wine can postpone the onset of Alzheimer's disease. And he tells me he takes every opportunity to indulge in that. But it's not just red wine he drinks, because I've seen him necking a bottle of champagne earlier on. So he's not too fussy. And then Sarah Cullum. Sarah Cullum used to be an old age psychiatrist. But now that the word old is deemed a little bit ageist, she's now transformed into a specialist in later life, which is kind of similar. Sarah has helped set up the memory clinics in Bristol, and she's also working with some of us in the room around trying to develop a more primary care approach to the diagnosis and management of dementia. Derek, another Derek. Derek is a scientist, and he's a chief executive of a company that uses imaging technology to help find patients who would be suitable for clinical trials of new treatments for dementia. Unfortunately, no drugs have yet been found that can halt or change the course of dementia, but I guess we can't blame Derek for that. But a lot of Derek's work around imaging can be very useful in helping diagnose people with dementia, and we may be hearing a little bit more about that later on. And finally, Anne. I haven't forgotten you, Anne, don't worry. Anne's background is a nurse, and she works for the Alzheimer's Society. And the Alzheimer's Society, she's got the responsibility of really trying to bring to life people's experiences of living with dementia. But she does have some spare time, despite doing that. And in her spare time, she tells me that she really enjoys hugging trees as part of her yoga practice. So that's an interesting activity. Maybe you can demonstrate it a bit later on. Right, so ladies and gentlemen, these are our illustrious panel. We've got a few other people that have kindly given their names to me who are dotted around the audience. I have no idea where you are. but they may want to contribute during the course of the evening. We've got Sam Creven. Would you like to pop your hand up wherever you are? Hello, Sam. Sam's a GP trainee. He's got a real interest in dementia, and he's hoping to do a PhD around dementia screening and how we can help GPs develop the skills and use the right kind of kit to improve dementia screening. Angela Beattie. Angela? Hi, Angela. Hello. Angela is a researcher at the University of Bristol. Again, she's got a great interest in dementia screening, and hopefully we'll give you a chance to make a contribution later on. Mark Drain. Mark? Hello, Mark. I've seen your excellent tweets today. Well done. Mark's an architect specialising in healthcare design, and he's particularly interested in how the physical environment can be modified to help people with dementia and other disabilities. And Judy Howarth. Hello, Judy. Hi. Judy's a doctor. She works at North Bristol Trust, has been working memory clinics for many, many years, knows just about everything there is to know about dementia, as far as I can tell anyway. So hopefully Judy will have a chance to make a contribution later on this evening. So I'm going to get the ball rolling in a moment. The way we're going to work this is that two of our panel, we've got Derek and Chris, are going to give a 6-minute talk around the theme of dementia. Does everyone want an early diagnosis? And they're going to show their somewhat differing views. So they're going to have a 6-minute slot each. I'm going to herd the panel off and sit out of the way there so that we give them a chance to roam the platform and we don't get a stiff neck staring up at the screen. And then we're going to get everybody back again and then take it from there. So Chris, would you like to go first? Yeah, okay. Right, we'll just head off and give you a bit of space. Over to you.
When I arrived at lunchtime, it was windy and rainy. I'm in Norfolk. We had a sort of dust storm, so it's nice to sort of settle down to this. I really am very impressed with the audience. You all are coming tonight, and the interest, which has really sort of inspired me in some of the work we do. So I just thank you for coming and listening to our talks. And I think this is a great event. And I did speak to the Dementia Czar last night, and he said that, get out there, Chris, and let's have a discussion. And that's what it's about today, talking about dementia and what we can do about it. A little bit about me to add. I was an RAF psychiatrist, so it's true. I did that for 12 years, then I was in the NHS, and then I became an academic. And I'm at the University of East Anglia, not UE, so Norwich. Oh. So, I used to work with Richard Gray before. So the title of my sort of presentation is, Do I Need a Brain Scan Every Year? Why Population Screening Might Be Bad for You. This has already been alluded to some extent. We face a huge problem across the world, not just in England, but in America, Europe, Australia, wherever you go, with escalating populations. And the graph there on the left, which is my simulated cost graph, is the annual cost of care in the US. Latest figures released about 2 weeks ago in, I think, the New England Journal of Medicine. And it's escalating out of control. And that's why President Obama has signed off various acts to try and get more money and innovation going. And in fact, in America, they've just introduced an annual 75-year-old healthcare check, which includes 5 questions about your memory. The trouble is, my dear American colleagues, and I advise and I work with pro and anti-screeners in the States, no one can agree what happens next. Some are saying they should go in a brain scanner. Some are saying you should use the mini-cog. Some are saying the CAN-TAB. There's just a row. So there's a bit of chaos at the moment because everyone's using different tests. And that's a big problem if the tests themselves need further development, maybe. So, audience participation time, please. And I'm afraid we've got poor acoustics. What I'd like to know from the audience, and I apologise for the title, but it's the TEDMEDs that's what the theme they wanted. What do we think is the key to the dementia tsunami? Can we just have a few words from the audience? Take 5 people shouting something out.
Drugs.
Okay. Legal drugs. Yeah.
Lifestyle. Yeah, legal drugs.
Excellent. And I'll show you why. Prevention. Good. Excellent. And one more, please. Good. Now, how many of you in this room tweet? Can you put your hand up? Well, you've got lots of time. I went on a course. Now, this afternoon, after the TEDMED talk, I've been battling with politicians all afternoon. Some of you may have picked up some of the media press. And I got a phone call out of the blue from my office saying, oh, look what's appeared since he saw your talk on Twitter. Now, Jeremy's really nice, but I think he's picked up some of the things you have. Forget the just did dementia debunking area, there's no point in early diagnosis, but medicine, good care, and lifestyle change. Now, he knows that can slow onset of dementia. Does anyone believe that? No. Is there a trial? No. So where's he got it from? I've been told there have been thousands of tweets since 3 o'clock saying, show us the evidence, Jeremy. So that's one of the answers possibly in the future. I think today, maybe he's wrong, but in the future, hopefully, he's right. What I think, it's about quicker diagnosis, getting there faster. There used to be a story some years ago that it took the average patient with dementia 3 years for their specialist and GP finally to diagnose them. Now, it has improved a bit, but I think it needs to be a lot faster for those who are symptomatic. My worry is that a lot of asymptomatic people, worried well, will end up dragged into a screening program and end up with a label. It's something that Derek might allude to later, something called MCI, or early MCI. Has everyone heard of MCI? I'll tell you what it is. It's thought by some to be a pre-dementia state. It stands for minor cognitive impairment. Now, the problem with that condition is that there are numerous subtypes, and not everyone converts to dementia. So if you ended up with a label like people in my specialised MCI memory clinic do, and they say to me, OK, so what does that mean? And I say, well, it means you can come into some of our MCI trials, which may be starting soon, but otherwise I can't really tell you because you may or may not get dementia, you may or may not need to plan for the future, you may or may not need to set up power of attorney. We don't really know. So the problem is that the research base isn't there over time to say what happens. There is some evidence, but it's not good enough in Cochrane or in grading standards to be definitive. So what's the problem with that? Well, if we start labelling people with a condition that doesn't progress or too early, there are harms. And I've alluded to some of them here. We had limited drugs. You said drugs would be good. We've got limited medication with at best limited effects. We could lose our home, your mortgage potentially. You could worry about your employment. Social isolation is seen. There is loss of independence, loss of access to healthcare. People with dementia, it's time and time again, and I've just been given a £2 million grant in the Department of Health to look at hospital care. It's poor hospital care if you get dementia. If you come into hospital and you've got dementia, what happens to you? Well, they blame everything on the dementia, and for some reason staff often forget basic medicine. So we've been tasked in the next 5 years to try and sort that out. So it seems to be a sort of diagnostic overshadowing, even in the early stages. So I think these sort of issues are a huge issue. But there are some benefits, and I like to show a balanced side, even though I've only got a few labels there. The benefits purported are you can empower people, which is good sometimes, autonomy, maintaining health. They can set up advanced care plans. They can access telecare. Now, I highlight that one. There's no evidence that telecare is of benefit to people in dementia. All the trials so far have been negative, and we've just been commissioned again by the Department of Health to do a 5-year study, and I'll let you know then if it works. But at the moment, people are saying it works, and there's no evidence. We've scoured it, and we've been funded by the Department of Health to look at it. So when you see that message put out, oh, you can get a robot or an access to some kind of automated device if you've got dementia, it'll work. The evidence is just not there. Perhaps maintaining your health. Well, I've said, if you go back to that, if you get dementia, for some reason, often people switch off about the comorbidity. So is that really true or not? The problem with all of this is, if we do it too early and we don't target the right people, we risk diverting NHS resources. And my great concern is that if we set up very early diagnostic services or the wrong sort of early screening programs, where's the money coming from? Where do you think the money's going to come from?
Social care often.
Or other services or existing dementia care? Because the argument goes by some that if you diagnose early, you reduce costs because they can plan early and they won't go into nursing homes. But the evidence is not there. There are no economic studies of any credibility, and we've just done a review, and we're going to produce this in a few months' time, which shows that there is a cost benefit. There is a US study, which my friend's doing, large-scale report in 2017, So today, no, maybe in the future we'll have the answer. I know it's an American system study, but it's something. We need to say, well, if we put our pounds in this particular models, will it give us benefit? The other problem that seems to be happening since the last few months, since a consultation was produced about the new GP contract and what standards should be for dementia in primary care, we need to do this early diagnosis. The cart is pulling the horse. The horse is the science and the nice and evidence-based, whereas the cart seems to be pulling the other direction. And it's very interesting that if you look at what the latest NICE commissioning guide, it says, we do not want screening. And yet there are documents out there and government sources saying, well, actually, we do want screening for early diagnosis. But there seems to be a great deal of confusion about whether it's population screening, whether it's targeting specific groups. What is it? I have my roadmap. I would like to diagnose people quickly and early, but appropriately. My roadmap is 5 points, and I've mentioned this before, earlier in the early today. I want to look more at perceived benefits and harms, because I accept that planning is good, I accept that empowerment's good. But we've also done work which shown that people can become very depressed, suicidal. We did a survey in 10 to 55-year-olds, and they were compared to Americans, and the Americans said, yes, we'll take anything, because they love pills and healthcare. The Brits said, yes, we'd like to, but we'd probably become suicidal and depressed if we found out we were. And that was significantly different between the American population. The Americans were astounded, but one argument was that they were all under psychiatrists anyway, so don't go there. That's point one, okay? Point two, I love biomarkers. I was designing a trial with a substance called colostrin, and we just put that in, which is derived from cow's milk. And I said, let's do a PET and get me the best marker, because I didn't know much about it. And I said, I went to an expert and said, okay, what's the best marker? This one, he said. How good is it? 38% accurate. And I went to Cochrane and said, is that true? They said, yeah, we can't put people on a scanner. It's only 39%. Yeah. And that's reviewing all the literature. So I said, well, that's useless. How am I supposed to diagnose it? They said, well, you can use some pen and paper tests. Well, how accurate are they? They're a lot better, but only up to 80% perhaps. So 1 in 5 of those will get a false positive diagnosis. So we need to improve those, okay? We also need to better target specific groups. And an argument put around is that people with diabetes, arthritis, asthma, high blood pressure, who go for routine testing anyway, when they're seeing the practice nurse, the nurses should be skilled, or the GP skilled up, so they ask about the memory. They talk to the family. Then they perhaps initiate some simple tests. Because those are risk factors for potentially getting dementia, and it's opportunistic. It's so-called finding the cases when you've got a moment, rather than sending a letter through the post to someone who's 75 saying, come for your annual memory test, which is potentially one idea that's being put around, okay? The other bit I think we need to do finally is decent economic studies. I'm sorry to go on about that. You know, we had the Aricept wars when these cholinesterase inhibitors came out. I was there. People were using their attendance allowance and their pension to pay for it because health authorities would not pay for it. There were counter-economic models put up. There were drug company-sponsored ones, NHS-sponsored ones, and in the end, NICE sorted it out and eventually agreed 10 years later that they should be provided or whatever it was. I don't want that again. I think we need to do that early and quick so we can, if necessary, put the whole horse and cart the right direction as opposed to the way it feels at the moment. Just one final point. In the last 3 months, there have been nearly 175 rapid responses to the BMJ about screening and early diagnosis. And this is turning into a bit of a war and a discussion. And there's a lot of information flying around. I think what we're doing tonight will helpfully sort of clarify that and also will spread wider. And I mean, today this has been on 5 national newspapers, Radio 5 Live. It's been picked up by the media big time. And it's responded, Jeremy Hunt and the Tsar contacted me. I've had a tweet through that. So people are listening and they said, great, we like it because we want the conversation. We want people to talk about this. Thank you.
Thank you very much indeed, Chris. I'm sure you got loads of burning questions, but hold on to them because we're going to move straight on to Derek now, and then we'll open it up afterwards for all your questions and thoughts. Over to you, Derek, for perhaps a slightly differing view.
Yeah, so just remind people of the title. Early diagnosis. Does everyone want it? So I think we need to start by thinking, what is the purpose of a diagnosis? And there's a report that came out last year from the All-Party Parliamentary Group on Dementia that had more than 1,000 submissions. And that the conclusion they had was a diagnosis can give people that control over their life. It can empower, in the words that we heard earlier from Chris. It can help them plan the future, manage their condition more effectively, and then open the door to treatments, drug and non-drug treatments, which can help people maintain independent life, can help them play with their grandchildren for longer. And so, for example, the NICE guidance for the use of donepezil, which is Aricept, does say it's effective in the mild dementia group. So there are drugs where there is a lot of data to show they're effective, as well as lots of things where there isn't much data, some of which actually, the sort of things which aren't actually drugs or medical treatments anyway. They are assistive technologies, a whiteboard that helps you plan your day. Those things, of course, haven't had big randomized trials, and it's very difficult to envisage that being done for all the things that can sometimes help people.
Excuse me, can we clarify, is this evening only about Alzheimer's, or is it about the multiplicity of dementias out there that people are suffering from?
So it's about dementia, and this is a report about dementia.
Can you clarify for the audience that the issue of drugs for Alzheimer's disease is only for people with Alzheimer's disease?
So, for people with mild Alzheimer's disease, donepezil is recommended by NICE as being efficacious. For people who've got vascular dementia, there are benefits in other sorts of drug interventions, and there are certain other sorts of dementias where there also are potential benefits. But you're absolutely right. There is a hugely important difference between the different sorts of dementia. Dementia is not a disease. It is a whole group of diseases. Alzheimer's disease is the most common, the one which has been most researched. And so, very important point. The next thing I wanted to do is to come back to this word early, which I personally don't find terribly helpful. What do we mean by early? And I wanted to have a bit of a look at one dementia. This is Alzheimer's disease, which particularly in older people is by far the most common, but not the earliest, not the only one. And the reason for that is that what we know happens is that the brain shrinks. We know that we get all sorts of build-up of proteins in the brain, and that we know that there's a sort of molecular biology process that goes on that generates such things. We don't really understand actually the connection between this and that in detail. There's gaps in the science, but we do have a feel for what goes on here. And of course, people are using this scientific knowledge to try and test new treatments. Now, unfortunately, no new treatments have yet worked. And perhaps it's worth looking at this graph to try and understand why that might be. So when we talk about dementia, we've got a sort of a 10-year or so course of a disease, which is defined by having both memory problems, which is shown by this green curve, which are getting worse over that time, and also having difficulties with general activities of daily life, which is this red curve. There's also all sorts of other things we can measure with scans, with CSF samples and so forth, which are the biomarkers that Chris referred earlier, which also progress. And in fact, they start changing much, much earlier. In fact, if we look at the whole course of disease, some of the earliest things to change, like the amyloid in the brain, goes up maybe 15 years before you get dementia. So a lot of people might have Alzheimer's in the brain and die, might have amyloid in the brain and die entirely free of dementia because they're still at this sort of stage well before the symptoms develop. So when we're talking about Alzheimer's disease, right, we're not just talking about dementia, just as when we're talking about dementia, we're not just talking about dementia caused by Alzheimer's disease. All the dementias are caused by progressive processes which very often start getting worse and worse. And of course, if you're sitting somewhere like here, you've got what Chris was referring to as this MCI, this mild cognitive impairment. You don't actually know whether you're definitely on this path or not. Anybody who gets here has gone through that stage, but the reverse is not true. If you're here, your chance of getting to there may only be 20%. If you're here, it's a lot higher. Now, so what does that all mean if we're thinking about the question about early diagnosis? Well, it's important that we diagnose early enough, in my view, to do something about it. And by that, I mean to improve outcomes for patients, for family, and also for wider society, for this big economic crisis that's coming our way as the prevalence goes higher and higher as people live longer. And we also need diagnosis joined up with care. A really tragic thing that happens in the UK at the moment is sometimes the very best places at diagnosing you go to the very best neurological centres, and there's a good one here in Bristol, and there's or the very best psychological centres, psychiatric centres, and that they will give you a great diagnosis. But then you go back with a diagnosis, and actually the community GPs and practitioners aren't actually so good at helping you. And similarly, if you're diagnosed in the in the community, then very often you also aren't very well linked up, even though potentially you could be more so. So I think it's terribly important when we're looking at this whole question, what we mean by early is early enough to do something, and that is a moving target. So I want to come back to this graph. If we look at what the science is telling us at the moment, it's probably no point with any of the treatments that are currently being developed in looking at this group here, the people who actually have got dementia past the very earliest or most mild stages, right? And that's true not just of Alzheimer's dementia, but also other sorts of dementia where once the damage is really serious, it probably can't really be treated. That's where the scientific consensus is going for many types of dementia, particularly Alzheimer's. This is the area, this sort of mild dementia, where certainly you can do things now, if it's Alzheimer's dementia, for people with donepezil. It can give them extra 6-12 months of independent life if combined with other things. But where people are looking at treating with the newer drugs, which might make a much bigger difference than donepezil, is in this stage where you're going back into the MCI group. We're going back into a group of people which have not got dementia, but they are on the path to getting dementia, and if you can find them and give them a drug, maybe the drugs will work in those groups. So the theory that people have for why the drugs that have been tested, the billion-dollar studies that failed over the last year or so, the reason they failed could be that people were being treated up at this end of the spectrum rather than down here. And so there's now some even bigger studies going on, costing phenomenal sums, which are looking at potential drugs treating this group. Now, the great majority of the interest is in treating Alzheimer's disease because the drug companies are going for the most common dementia first, but increasingly we're seeing people looking at other dementias, and that's a very important point. And increasingly we're seeing also greater interest in vascular dementia, which hasn't, I think, had as much attention as it should have had. So now coming back to where we are today. So what I'm trying to explain is early diagnosis, where it's useful, is a good thing for patients and for society more widely. What early means is going to change as new treatments become available, and as Chris says, as more data becomes available about current interventions, whether they're drugs or otherwise. But what we see if we look at how good different parts of the UK are at diagnosing is that some, like the green area here, which is north of where the Romans got, they're much better at diagnosing the people with dementia than people are in the west of England here, where actually Bristol's a bit better than some of the other places around here. It's not so good, right? So there's a postcode lottery about how likely you are as a person with dementia to actually have a diagnosis. And the things that a diagnosis can give you, which aren't magic bullets to cure it, but they can help you live and die better with the disease, right? Those things are less common in some places than others. And what I think the Department of Health is trying to do in their initiatives is to say we need to do what is done well everywhere. And we need to try and incentivize the health systems to do that. So we get good practice everywhere by simple incentives. As Peter was saying earlier, in Bristol you're about in the middle, about half the people have a diagnosis, and we could and should do better here, as we could in so many other places, including some parts of Norfolk, where Chris is, if we look at that compared to, say, Scotland. So we must look at this question in terms of the patients and their outcomes. We must remember that as treatments come along, we will need better tools because we will need to go earlier, and that we will probably need more and better tools to go earlier. But at the moment, I don't think we're serving patients very well, and we need to look at how we do that better. And while this is a debate, I think we want to join up the polarized BMJ controversy, screening or not screening. I don't think the word screening is helpful. I don't think the word early is helpful. Let's look at what we can do for patients now and how we can improve that in the future. Thank you.
Thank you very much indeed, Derek. The rest of the panel are now going to be herded back onto the stage. And what we're going to do now, just to introduce the panel a bit more and get them involved, is I'm just going to simply ask them a question or so, most of them, and give them a chance just to spend a minute or two reflecting on some of the things that they may have heard from Derek and Chris's speech. So do hold on to your questions, because once we've done this, then it really is a chance for you to tell us your thoughts, tell us your comments, and ask your questions. So I'm just going to start off with Rick, actually. We just heard two slightly differing views on this. I mean, how important do you think this kind of whole assessment thing and screening really is?
Well, it's very interesting listening to this, and I suppose this notion of what should the balance be between trying to achieve a diagnosis and then following it up afterwards. Scratching my head trying to think of the right analogy, but I used to coach my son's junior rugby team, and the last year of their mini rugby they introduced kicking. So the tactic was that if you're in trouble near your own line, you pass the ball to our Welsh fly half, because every team has to have a Welsh fly half. So we'd whirly the ball down the other end of the pitch. And the thing we tried to get across, not always very successfully, was the rugby cliche that kick is only ever as good as the chase. Diagnosis is only ever as good as the follow-up, unless it matters that you do something different when you get there. My own feeling is very much, well, what's a good kick chase, what's a good chase, what's a good post-diagnostic support? Scribbling down this in the all-party parliamentary committee that it's about planning, managing, opening the door to new treatments. I'd just like to help. Seems to me it's important we think that's very easy to say. What does it actually mean to help somebody, and that we've given the diagnosis and helping their family to think about planning and managing? My experience of working in memory clinics and working with voluntary groups like the Alzheimer's Society, Alzheimer's Support, where I work in Wiltshire, is there are a lot of people who are trying desperately hard to do that. But there are all too often what we give people, it might be, you're right, we were saying earlier about the difference between Alzheimer's and if you've got mild Alzheimer's, we can give you a drug. It's often, we write care plans when we discharge from the clinic, which will often give you the address of the local support group to go to. And some information leaflets. But actually, we're really serious about helping people to plan and manage. And we have to really help people to think about what's happening. And that's not an easy thing because this is an evil illness. It's really awful. And if we're really serious as a society that this is what we want people to do, then we have to give them far more support than even the, and I'm not trying to disparage our current services because people are working really hard. But it is an enormously complex and difficult thing to help people, if you like, to adjust and come to terms, which is what you've got to do before you can go on to do this. And I know there are some people here with dementia tonight, and maybe they can say something about what that's like for them. But my experience is that it's often greatly underestimated by those of us who are giving the diagnosis just what a difficult process and how little support often we despite meaning well, we're not always doing as good a job as we can in helping people to do those things, to plan, to manage, and to get them to acknowledge that they need other treatments.
Great, thanks very much, Rick. I mean, Richard, we've been talking a lot about screening and testing. Who's actually going to do all of this screening and testing? Are they any good at it?
Are they any good at it?
It's a difficult thing to do, to get it right. It's important, isn't it?
I guess I've heard Chris and Derek talk twice now, and that wasn't a joke. I've heard Chris and Derek talk twice, and I guess I've heard lots of kind of noise about screening and diagnosis, and I guess the thought that's lodged in my mind is this doctors being doctors and worrying about the things that doctors worry about? Because I guess it's not so much about diagnosis, and I want to pick up on Rick's point, which I think is a really important point. It's about the care that people need afterwards. So yes, we need to get the diagnosis right. If we get the diagnosis right, have we got particularly good treatments? No, we haven't really got particularly good medical treatments at the moment. And there are probably some fairly significant arguments to have about whether we throw billions of pounds after finding drug treatments or testing more and more drug treatments that don't seem to be particularly effective, when actually perhaps what we need to focus on much more is about the care that people with dementia and perhaps more importantly their families require. And I think if Staffordshire has told us anything, it's told us that actually the work that nurses do caring and supporting people with dementia is incredibly is incredibly important. It's very difficult work, and that's something that we need to help and support nurses to do, which was a very good way of not answering your question at all, Peter.
I'm sure there'll be plenty of people going to pick you up on that in due course. Derek, I mean, the popular perception is that dementia is all about older people.
That's right.
Is that true, and is that really what we need to be thinking about?
Well, it's true that the vast majority of people with dementia of all sorts are older people. But there's a significant cohort of younger people, among them my wife, who began to show symptoms of dementia in her early 50s and is now in her late 70s and still living with it. And the problem faced post-diagnosis, which is what Rick and Richard have referred to, for younger people is almost an order of magnitude worse than for older people. There are virtually no services out there to look after people and support the carers of people who have dementia in the early 50s. I went through a very difficult time with my wife because she was a very good walker, very young and vigorous physically, but very confused and with very short-term memory loss and so on. And there was no service out there that I could find until the Alzheimer's Society came up with a particular day centre which caters specifically for younger people. And that's more or less unique in the country. There are very few of those anywhere, which help the carer to get some respite from looking after a younger, vigorous person. There's also things like when you're younger, when you're in your 50s, you're still working, you still have a mortgage, as somebody else has said. You're still driving, you're still supporting your family, you still have a job. All those things are suddenly threatened, and you have to somehow or other navigate through those very difficult waters. So I really wanted to make sure tonight that we didn't forget that very significant number of people who in their early 50s and maybe even younger are contracting the symptoms of Alzheimer's.
Thanks. I mean, that's an important point, that although there are fewer of them, they have their own kind of set of, not unique, but particularly challenging issues and problems for themselves and their carers. So hopefully we'll be able to come back to that. Anne, from your point of view as working with the Alzheimer's Society, what's their stance on making an early diagnosis? Where do they stand?
I think we've already said, I hope my mic's working, I think we've already said that we recognise that 46% of people currently have a diagnosis of dementia, but therefore that means 50% of people are living with memory problems that they might not even recognise as dementia, or they know themselves through the precipitating conditions that they're actually relaying to themselves and recognising in their hearts that actually something is not quite right. And our stance on it is actually, why shouldn't those people at least encounter some understanding of that so that they can start planning and living their lives for the future, can access the support and treatment that they and every one of us deserves. And, you know, fundamentally, it's about informed choice. And yes, I recognise early diagnosis, and we talk about the younger people, but the reality is that people do want to know now what's going on, and many do describe a case history, a diary of years of not quite knowing what's going on. So we, the Alzheimer's Society, are supporting any opportunity we can work with healthcare professionals and other third sector organisations to ensure that people have the right to live the lives that they want to live.
Oh, thanks very much, Anne. Sarah, I mean, you've got a senior role within a health trust. You've got some responsibilities around training and educating other more junior medical staff and nursing staff. What do you tell doctors about diagnosing, how to go about diagnosing dementia, and what's important about that?
I think, is this working? Yeah. We've talked about it a lot today, about this kind of uncertainty principle, and I think when you're diagnosing dementia, sometimes you can be 100% certain, but very early in the disease you may not be, and there are, as we've talked about, lots of other treatable causes that you need to look at, reversible causes. They may even be in the environment. And also, when you're looking at subtyping dementia, I mean, you've heard about how Alzheimer's is most common, but we don't absolutely know that for certain. And even in post-mortem studies, that what looks like Alzheimer's in life isn't always as a post-mortem study. I'd like to just come back to this early diagnosis, because I think the term has changed. When I work in a community mental health team, and I've also worked in general hospitals, and I've been astonished sometimes when you meet people who have got very obvious dementia and it's not been picked up by anyone, sometimes because they live alone, or just people have just got used to it, or they think it's normal aging. Now those people, I think we'd all agree, would benefit from an earlier diagnosis, because they often present in crisis, or they come into hospitals, or sometimes it's a mental health act assessment, that because it's got to such an awful state. I don't have an issue with that, but when we talk about early diagnosis, as in earlier in the process of the disease, I think that's when this uncertainty principle comes in. You're looking for a needle in a much bigger haystack, and I think you need to acknowledge that. This is what I would say to junior doctors, is that we have to acknowledge what we know and what we don't know, and we need to involve people with whatever problems they're presenting with, and their families, in making decisions about how much they want to know. I mean, we need to respect people's choice. And in fact, we have a primary care liaison service now in Bristol, and about up to 30% of people who have cognitive problems, they don't want to go any further. They don't want to know. Now, that may be because of the stigma attached to it, but we need to acknowledge that, and we need to work with that, and I think that's part of this debate.
So really, diagnosing people earlier and earlier, I guess, is harder and harder. I mean, It's harder to do that. So what might be, what are the real implications getting the diagnosis wrong?
Well, I think, as Chris was saying earlier, just the anxiety associated with that is going to be probably the worst thing. And not just for the person, but for the person's family. I mean, as I'm sure Derek would say, it changes your relationship when you suddenly become a carer. So, I think the psychological harm of getting the diagnosis wrong is probably the worst thing.
Right. Well,
Peter,
thank you. Yes.
Can I? Because I've been having heard the talks twice. I've had lots of time to process it, and I guess to people who present themselves as scientists, and I guess if I was being a bit argumentative, what I heard was quite a lot of opinion. I think that this would be a good idea. I think early diagnosis would be a good idea. And I guess the thought that's running around in my head, and I don't know what other people think, is that it's kind of a research question. It's a question. We don't know whether screening people and identifying people earlier and early intervention actually is a good thing to do. And it's kind of been troubling me in the back of my mind.
Right. No, I think the most important thing you said there, Richard, was we don't know what people feel. So I think this is a chance for us to find out what other people feel about this. We've had a number of different aspects of this complicated, important area raised around the needs of younger people with dementia, the pros and cons of trying to get this diagnosis as early as possible, some of the advantages that can come from perhaps getting a diagnosis and taking some control over one's life, and making some planning, and perhaps having some access to treatment. So quite a few different issues have been raised. But now I think we all really want to hear your thoughts, your questions, and your opinions. So let's get those roving mics working and start popping up your hands. Right. Gentleman in the middle there. Yep.
I'm 50.
And do feel free to direct your question, if you want, to any member of the panel.
So I'm 50, slap in the target group of people who might have it beginning and don't even know about it. The graph that Derek put up there was really interesting, that there are some chemical markers that start long before symptoms ever start. So I think I've got an observation and a question. And the observation is, I would be in favor of early screening and diagnosis if it meant there was stuff I could do to prevent the symptoms starting sooner. So that's how I feel. And the question is, so we have some chemical markers that seem to correlate with dementia, and they start rising very early. Do we know if there's a causative relationship? And do we know if we can do anything about those chemicals? And if we can, what are the side effects? Thank you.
I think that's for you, isn't it?
Yes, so, great question. Okay, so the first point is that at the moment, the answer to pretty well all those questions is there isn't really enough data to give an answer to them, right? What you can say is that there is very strong evidence that those markers are associated with the disease, right? But there's also very strong evidence if you kind of take away some of those proteins or those markers very late in the disease, it doesn't actually help you. Nobody's yet answered the question, if you take away those bad proteins, if you can think of them in that way, earlier, before you have dementia, will that help you? Those research studies are being done at huge cost. Not at the very earliest pre-symptomatic stage, but at the stage where you've got memory problems, but not dementia. So I think it's very important that we talk, dementia is when you actually have problems with activities of daily life, not just a memory problem. And so when we talk about early dementia, we're talking about those people who already are having problems, not those people who may in the future. So 50-year-old, got amyloid in your brain, why would you want to know? Answer, I really don't think you would at the moment, right? I would never be advocating everybody at 50 had a scan to see whether they've got amyloid in the brain. It would be, there's no evidence at all that that could improve your outcomes or anybody else's. There is evidence of the opposite. There has been a study, and Chris was referring to one he's done himself, where people have shown that knowing that you've got amyloid in your CSF or your brain, it actually can cause depression if you're asymptomatic. That's not a good outcome. We don't want to have bad outcomes. We want diagnosis which helps good outcomes.
I mean, we're talking very much about Alzheimer's disease here, aren't we? And it goes back to that really important point earlier on. What about, you're basically saying there's not much you can do at that stage, but other kinds of dementias or even parts of Alzheimer's can have a vascular component. So there are things presumably that we can do about that in terms of prevention.
Yes, I think there is another question which again hasn't been answered, which is to what extent can you intervene with your lifestyle at the age of 50 if you've got amyloid in the brain and help you? So, but arguably you could just look at your ApoE4 carrier status. You could do a simple blood test to look at your gene, your ApoE4 status, which is a really big risk factor. It massively increases your chance of getting vascular dementia or Alzheimer's disease, right? So, and you could say, well, actually, if I'm at risk, would I change my lifestyle? And if so, how should I change it to minimize my risk? Again, those questions aren't really answered, right? So I think it's still the case that we don't have the data to answer the question, yes, we do need that information because it can cause a change in behavior or a change in intervention to help the patient. But there's another big but. Why are those markers interesting? They're interesting because the best thought anybody has at the moment is if we're going to treat people, we probably have to treat it before so much damage is done to the brain that it's unrecoverable. So those markers are very useful in testing new potential drugs, which of course have to be reasonably safe, such that we may be able to stop people progressing. We can delay, just like in cancer, you want to delay progression. With dementia, you want to delay progression. And that can apply to any dementia. The same, and often there's often, in many other dementias, there's also a bad protein involved, if you'll excuse the simplification, and that also can be targeted, and you can also try and delay that development. So those markers could become useful in the future. So just because they're not useful for you now, doesn't mean in 10 years' time, it wouldn't be useful for your younger brother.
Can I just add that the politicians, though, from that tweet, do believe. If you look at the lifestyle change, that is from Jeremy Hunt. So there's something wrong there, isn't there? There's a disconnect.
There's a lot, I'm going to go back to my same point and repeat it. There's a lot of opinion and not a lot of hard evidence, good science about what we should and what we shouldn't do. And I think that is an important observation. Yeah, politicians shouldn't go around spouting opinion. We want evidence-based medicine. I guess we're all working on the fact that evidence-based medicine is a good thing.
But if we were in the States, Richard, we wouldn't care because we can solve the economy problem, we can write blank checks, we just throw money at it, which is what goes on in Indianapolis and other places I visit, and you're quite shocked. They'll try anything, even though there's no science in it. So I think British, we're a bit more rational, scientifically based, evidence-based focus, and the Americans live less than us, they have worse health than we do.
I don't think we should be judging our mental state based on American colleagues. But that's
I sense where this is going. Sunita, you had your hand up earlier.
Yeah, my question is political.
Can you just wait for the microphone? Sorry.
My question is a political one, because in reality, the analogy that you were seeking at the beginning was the analogy of the, I don't know, I'm old enough to remember the old AIDS adverts, when the tip of the iceberg was basically there. Nobody had any answers to AIDS, but everybody wanted to diagnose AIDS. For what purpose, I have no idea whatsoever, until triple therapy came on board. And fundamentally, when you are living in cash-strapped times like this, do you divert the money which goes at the moment to social care, for example, and social care budgets are being cut by 30% on average, into healthcare pots, which hasn't had a cut in reality? Okay, arguably in real terms we've had a cut, but not in real terms. We still have £100 billion worth of a budget. We have no answers in healthcare for anybody with Alzheimer's or many of the other dementias. And while we don't have answers, we continue to take money away from the bit that works, which is supportive care. I find that astonishing that as a society we continue to do.
Is that directed at anyone in particular?
Well, I would just like an opinion.
So I kind of agree. I think looking after somebody with dementia is an incredibly difficult and challenging thing to do. And I think if you're a mental health nurse, that's something that kind of comes with the territory. Chris was alluding to this earlier. But actually, looking after people with dementia is something that nurses have to do on general wards. It's something that district nurses need to be doing when they're going out and changing ulcer dressings. Looking after people with dementia is a critically important part of healthcare. And I think one of the things that we need to do is we need to help people to look after people and their families with dementia much better. And I think we have got some fairly reasonable evidence, and certainly we've got some fairly reasonable inquiries that emphasise how important that is. And I think in cash-strapped times, that's perhaps where we should focus our attention and maybe not divert that resource to ever more research around drug treatments, perhaps.
I'd just like to bring Anne in here. I mean, Alzheimer's Society is quite keen on the idea of promoting an early or appropriate timely diagnosis. I mean, what do you say to this thought that it's actually a distraction, that it's removing resources away from the caring side?
Yes, and we've certainly had a number of different policies associated with that. But I think what we also say is that living and learning from people living with dementia, it's about them wanting honesty and them wanting continuity. And there is a great advocate, we're a great advocate for us trying to work as organisations together in some sort of considered way to enable people to have the opportunity and choice about living well with dementia. And it's not just about health and social care people that we should be targeting our resources to, which is why we're doing a very big campaign at the moment around dementia-friendly communities. So if I had dementia, I wanted to continue working and going into Marks and Spencer's or even my local shop. Those people were fully aware that I had dementia and they could assist me and support me in continuing my life in the way that I wanted to do. People, we are learning all the time around what people want, and people want honesty and they want continuity. And you can see from the experts at this panel that we are so committed to working together as organisations to ensure that the pathway, that the journeys that people have, carers, families and the person, sometimes we forget the individual with dementia, we actually are committed to working in a more coherent, coordinated way.
So do you think the process of encouraging a bit more appropriate diagnosis actually helps society more broadly become more accepting and more dementia friendly?
I think the difficulty we have at the moment because of this debate is actually people still feel very stigmatised and discriminated when they have a diagnosis. I have heard people say to me that they walk into a memory clinic or to their GP practice as two individual people, and yet they come out of that particular clinic or outpatient room as a carer and a patient. And I think we have to recognise that people in those situations and how we give that diagnosis has a significant effect on how people want to live their lives for the future. If you are saying to somebody, you have dementia, and this is how it will be, and this is what likely to be, and this is the treatment that you might like to consider, and this is the support that's on offer to you, and actually go and have a jolly good holiday and start living your life, to a different perspective where there's nothing much for you, and I've heard that and I've witnessed that, it's incredibly difficult for those people to get their heads around that. So it's about a society issue as well as health and social care issue.
Yeah, and that important point of how you frame the whole conversation. It can either be framed as a negative doom and gloom, or actually about empowering and taking some control. More questions? There were definitely hands up. Gentleman again in the middle row on the right there.
Yeah, I'd just like to ask the panel what they think about conventional medicine against herbal medicine. It was only reported only this week, just gone by, about the University of Hull with rosemary helping the very thing you're on about today, to breathe in and inhale as much as possible to help the onslaught of Alzheimer's coming too soon. Have you got anything that would help so that we can consume something rather than having the drugs, which sometimes the drugs are causing a lot of the problems we got in the world today?
Herbal solutions. Does anybody have any thoughts about that?
Yes.
I thought you might say that, Richard. You got thoughts on everything.
Yeah, that's why I'm not speaking.
Go on then.
I'll default to my point. I think we need good quality evidence, and we need to know what works and what doesn't work. What we don't need is opinions. And I think, yes, herbal treatments may have some benefit, but what we need is very good evidence from very well conducted randomized controlled trials. And I think people with dementia and their families are quite vulnerable. And I get worried about stories appearing in the media about miracle treatments for a variety of things, which quite often turn out not to be true. There's a new yogurt, I don't know if people know this, Chris knows about this. There's a new yogurt drink that's being marketed called Sovereign Aid, which is a kind of a food supplement, which allegedly prevents, if you take it with mild cognitive impairment, it's allegedly meant to be very useful. But the evidence from clinical trials is incredibly dubious. And I think as clinicians, we need to look very hard at evidence, but I also think that people, that the community need to also think very carefully about the evidence that's presented to them. That was just a rant about evidence, really, wasn't it?
Make a sort of...
Yeah, just because it's a university study doesn't necessarily.
You'd know all about that, wouldn't you?
Just to add a point. So I think when people have taken drugs and they're taken into really, really large multi-thousand patient studies, they've done so on the basis of smaller studies of, say, a couple of hundred patients where it looks promising, right? It's very easy to have a drug that looks promising in a few dozen or 100 patients, 200 patients, but when you do the proper big study, actually it really isn't. And I think that's the problem we've always got, is the problem with actually the scientific method. There's always a chance of you getting a misleading result, and that you reduce how misleading that could be by doing a bigger study. And the way you test treatments is you start with a small one. If it looks promising, you go to a bigger one until you get to one that's so big that it's, that regulators that are looking after our health say that's strong enough evidence, we should now allow this to be used on patients. And so the problem with so many of these small studies is that they are in that area where you just expect by pure chance quite a sort of false positive. And so we do have a problem. There are going to be quite a few, even though they're sort of university studies or they're company-funded studies with properly designed, properly carried out, there are going to be these incorrect results until those really, really big ones have been done, and that's hugely expensive. That costs hundreds of millions for each study.
Can I just add that the FDA in the US is proposing relaxing regulations so that they will let licensing through at a lower bar. So can anyone see the problem that if they accept a lower standard of evidence, smaller studies, what are we going to end up with
Is this for all drugs?
For dementia drugs,
right. Because
they're so worried about MCI. They want to license things with a lower level of evidence. Problem with that? Anyone got a problem with that? Derek? do you
Well,
wanna
I've
say?
explained their thinking. So I've spoken to Rusty Katz quite a lot about that, who's the guy at the FDA. So the problem is, if you're trying the current way you get a drug approved for dementia is it has to affect both your cognition and your function, right? So it has to improve both for it to be approved. So what the FDA is saying, well, there's a problem with that. If you're trying to treat people who haven't yet got dementia, they've not got those problems with their activities of daily living, then actually you can't get a successful measurement on that, right? So they have therefore said, okay, if you're doing a study which is in that earlier stage before people have the clinical disease, because that might be where we need to treat people for it to work, we will let you submit data where you just show benefit in cognition. So your memory is better, your ability to plan could be better, right? Now those are actually potentially quite useful things to be better. They have to be, clearly there will have to be evidence that it really does help those things. But what they're saying is you don't also need to show that it helps your activities of daily living. It doesn't help you cook for yourself and dress and wash yourself.
When I got the stairs 3 times in a row and tried to remember why I went up there in the first place, and I had to sit on the bed in the 3rd time and I'm exhausted, I'd like to know if you can give me a tablet that will solve all my problems. Thank you.
I mean, my worry is
We would all be having those, wouldn't we?
my worry is
Rick.
something called snake oil, actually, to be licensed for dementia. You know, the old treatments with that sort of, with the tools that aren't fit for purpose. The old snake oil can cure anything, if you remember that.
And
like to give
desperate people end up spending a lot of money on stuff that doesn't
Souvenir
work or might even do them harm.
£2.50, and you have to pay for it.
I think we
won't
shouldn't
prescribe it.
ignore the public health message. You know, what's good for the body is good for the brain, and that, I mean, I don't know, you'll be able to tell me, Chris, if there's epidemiological studies that have shown that good diet has any impact on dementia outcomes. But it kind of makes sense, and that's the advice I would give people. Good, lifestyle, exercise, all of those things.
Yeah,
All the usual things that are actually good for many other conditions in life. Rick?
Two things. First of all, on this, first of all, the really big studies that people would accept as being evidence, well, I'm sorry, but the only people who fund that are the people who've got a vested interest in promoting large drugs. And that's good, but it comes at a cost, a social cost. So, but the second point is that there are a number of psychosocial studies. I'm not really addressing the point about herbal, but if you think about things that aren't necessarily to do with medicine, formal medicine, there are a number of psychosocial studies, particularly something called cognitive stimulation therapy. I'm not a huge advocate of it myself, but if you look at the evidence, number of repeated double-blind control trials is accumulating to say that engaging people with dementia in activity stimulation, teaching them rehabilitative techniques about memory and so forth, do both of the things that you're talking about, which are about improving functioning, improving quality of life, and improving cognitive status as well. So there are other things that we can do. We don't just have to think the cure is inevitably about a narrow set type drug.
Because I go back to my point. So if we've got that kind of evidence, we need to be doing more of that, and perhaps not getting so worked up about the appeal of early intervention. Early intervention is very appealing, but we don't have any good quality evidence that it is effective. I don't know, more of a question back at you, Rick.
Right. Is that you, Angela, there? Yes. Angela.
Hello, Angela Beattie from the University of Bristol. I'm a researcher, and I also have an interest in the experiences of people living with dementia. And I remember Dominic very well when I interviewed you and your wife many years ago. What I want to just come back to and focus, because I think we've gone away a little bit, the title of tonight's seminar was Does Everyone Want an Early Diagnosis? And whilst we may have skirted around, nobody's actually spoken about the acceptability of this proposed screening. It's already been introduced in secondary care, and no doubt it's about to come into primary care. But we have no evidence, there's no evidence out there looking at the acceptability. There's the evidence that we have comes from the US, and again it suggests that most people will refuse to go on for further tests because of the fear and stigmatization, the losing independence and so on. And I think we really need to focus on the individuals, their significant others, and also the health practitioners who actually have to carry out this screening. Because with no guidelines, there is no good guidelines there to help them implement it. And I know as a researcher and as a practitioner, it would be something I would feel very uncomfortable about actually being engaged with when I have no evidence base and no guidance to actually help me.
So Angela, could you, for the benefit of most of us here who aren't completely sure what actual screening is taking place, you said there's some screening taking place in secondary care hospitals and soon to be taking place in primary care. Could you tell us a bit more about what the screening is?
Yeah, the screening in secondary care, and Sarah can come in if I've missed any points, came in 2012, and it was followed by a cash incentive sequence. And essentially, so anyone over the age of 75 admitted to secondary care will be screened. Now, you could argue that is a good practice because a lot of people at that age come in a very confused state, and it's a duty of care to try and find out what has led to this confused, and one of the confused state, and one of the duty of care is to sort of assess for any evidence of dementia. But introducing screening in primary care is different. There's a different case mix. People present differently. So there's a real issue about misdiagnosing. I mean, we've already talked about that. But there is a real issue about misdiagnosing, and indeed the impact that that has, not just on the worried well, but actually the psychological harm of receiving a potentially misdiagnosis.
Thank you. Can we have some more contributions from the audience? I see hands up. Gentleman there with the tie in the fourth row.
Can I give a view as someone who's received a diagnosis? My wife has got frontal temporal dementia. She's had it since 1999, although it was only formally diagnosed 5 years ago. And looking at the graphs there now, I can see why. Thank you. But can I just say, there is life after diagnosis. The best advice we were given when we got the diagnosis was contact the Alzheimer's Society. That was the best advice our doctor gave us. Because when we went to the Alzheimer's Society, we were put in touch with drop-in groups, carer support groups. We organised our own activities, a healthy lifestyle. We set up a walking group. We go singing for the brain, which has been recognised as something that's really useful. Now, all this costs pence, whereas all the stuff you're talking about is down to medics. We've got no control over what you're doing. You know, the government might have, but we haven't. And do we need an early diagnosis? You bet we do. When you're given a diagnosis, thoughts flash through your mind. You think, is this a terminal illness? How long have I got? Where do I go from here? What support is there? Not just from the state, but from the voluntary sector. And when you walk down the road from the hospital, these thoughts flash through your mind. But there is a lot you can do yourself, and there's a lot you can do with your age group. I'm not old. My body says I'm 68. In here, I'm about 27. Okay? There are still things I like to do. I still like to dance, not very well, but, you know, my wife and I, even though she's got frontal temporal dementia, we give it a go. By being given a diagnosis, you're able to plan. You're able to plan your life. When you're young, you look forward to when you retire, or when we retire, we'll be able to do this, that, and the other. When you're given a diagnosis, in my case, I said, right, we're going to do it while you can still appreciate it. So we did a couple of cruises. We went to places we'd always wanted to go, and we sorted that side of it out. We also made sure we had this power of attorney in place. And there are two people that I'm associated with, and Anne and Derek know them. One's 44, one's 46. They're young. So if you're going to screen, what's your criteria for screening? What, are you going to screen by age? Because you can't. If you screen at 60, you're going to miss the 40-year-olds. If you screen at 20, where's the money coming from? So, you know, what's your criteria for screening?
Isn't that the point that you were?
Thank you. Thank you very much indeed for that contribution. I think you presented a really positive message, actually. No one wants to get a diagnosis of dementia, of course. But what you've expressed very eloquently is it gives you an opportunity to take some control, to have some power, to plan ahead, and in fact discover all sorts of new opportunities that you might never have taken had you never had that discussion around the diagnosis. So thank you very much. Richard?
No, I was going to say that I think that's the point that Chris was making. It is about early diagnosis, and I think you're making the same point, which is very different to mass population screening, because you're right. You've suddenly made me realise I hadn't thought about it. Maybe I'm in an at-risk group, and maybe I need to, when I get home, just quickly do a couple of tests to make sure that I'm okay. Where do you stop? And I will always default to the point that we don't know whether doing that level of screening is a useful use of resource, and we only have a finite amount of resource, and we need to think carefully about how we spend it, and we spend that based on evidence. And I think the points that you've made about the support that you get from the Alzheimer's Society are incredibly impressive.
Derek, it's quite a long time ago since your wife had her diagnosis. I mean, you've been hearing some reflections about diagnosis and early diagnosis. What are your thoughts? I mean, where do you come from? Where do you see this?
I think, excuse me, that diagnosis for the younger people is very difficult. I mean, when I was looking at Derek's graphs there, where would my wife fit on that? Where would somebody of 50 fit on that? I just couldn't see any correlation at all. I'm very much with the gentleman who's just spoken, that it is possible to live a reasonable life with dementia if you know you've got dementia and you plan for it. Like this gentleman and his wife, we also went on holiday. We had decided long ago that when I retired, we would travel around the world, go and visit relatives in Australia and Canada and so on. And so I had to retire early to look after her, so I had to leave my work. But we still decided that we would do those trips. We did. We were able to travel to Canada, to Australia. We went to South Africa as well. And we encountered very difficult circumstances. But we overcame them all. It was largely a matter of getting people to understand the problems we were facing. If I was able to explain to a customs officer or to somebody at a border control or somebody on a boat that was trying to make us do boat drill when she wouldn't put her life jacket on, if you can actually explain to people what the problem is, I found them incredibly supportive and being able to, being aware of the diagnosis, being aware of what we were facing, we were able to plan, we were able to do things which gave us a good quality of life. I was able to spend time with my wife that I certainly wouldn't have spent if I'd carried on working.
So in some ways, you're saying that
we made the best of it, I think.
You certainly made the best of it, but the interesting point you said particularly was that although clearly having dementia is a major problem, actually it's mainly a problem, or a lot of a problem around society's unskilled ability to handle it in insensitive or clumsy ways. So maybe one of the messages actually is about trying to educate and have more conversations like this that bring society in, so that when they do meet people with dementia on the bus or whatever, who are struggling to find their money, they just give them some extra space, don't put them under pressure. And I think there's a lot that perhaps we can do for society. There's a hand up over there on the left, lady. Can you wait for the mic? Sorry.
The one word that hasn't been mentioned tonight is fear. And
fear, did you say?
Fear. And that's not only the diagnosis to someone who is being told that they have Alzheimer's or dementia of any kind, but fear in the general public. And if we educate the general public about what happens with people with dementia, we would have a far better society. People are frightened. If they meet people with dementia, they don't know how to handle it. They don't know what to do. They don't know what to say. And therefore, education in the general public is as important as the things that you've been talking to tonight.
Time is catching up with us. Can we have any more lady from the front row, and then after that, lady in the middle on the right there. Really, last 2 or 3 questions, I'm afraid, and then we're going to have to be rounding up. I feel as if we go on all night.
Just listening to what's been said by the two husbands of women with dementia. I'm the dementia age, obviously, but just forgetful at the moment. But I have a daughter with learning difficulty who is 48. And the change in public attitudes and willingness to incorporate her in ordinary social life has changed so dramatically, particularly, I think, over the last 30 years. So it does seem to me that attitudes, other people's attitudes, are the crucial factor that's just been mentioned. And it works, as it's worked with the learning difficulty population.
Thank you very much. Lady in the middle of the middle row.
I work for Guinness Care and Support, so we deliver care for older people across the whole of England, and I wanted to make a plug for the Alzheimer's Society's fantastic training pack for staff. But I have a real worry. The public spending cuts that local authorities are imposing mean that our workers are paid such low wages, and we're requiring ever greater skills of them. I think Bristol has an opportunity here. You told us at the beginning of this evening that the Bristol public are saying dementia is their single biggest health issue. I'd advocate we ought to follow the model of York in becoming a dementia-friendly city, and I think we should build on that opportunity. The public have said that's what's important to them.
And I think that is an aspiration of Bristol itself. I think it's gained some funding recently in order to try and move the city towards this goal of being a dementia-friendly city. We can debate what that might look like, but I think we've heard some of the things that could be represented in a society, a city that is more open and receiving and just more educated and more understanding about an increasing proportion of its members who do have certain difficulties, but yet can still live perfectly full lives if they're given a bit of space and some help. Time is upon us, I'm afraid. I'm just going to ask our two star speakers just to wrap up, just 1 minute each. Just any reflections or any views about the cases that are made originally. So I'll start with you again, Chris.
Thank you, Peter. I'd just like to say it's been very inspiring to hear from everyone in the audience tonight, and that's been very helpful and useful. I think it's been a useful discussion. I'm going to make a plug, though, because I'm a researcher and I left the NHS into Ivory Towers because of that. Can you help us with this problem? There are projects going on. There are projects funded. And if you are interested in research, please contact your local Dendron office. Another plug for Dendron, because I'm a regional director.
Do you want to tell us what Dendron is? Not everybody here is going to know that.
Okay. Dendron, for the moment, because it's about to be disbanded, isn't it, soon? Changed. Is the Dementia and Neurodegenerative Research Network, and it's divided up into regions, and I am Suffolk, Norfolk, Cambridgeshire's regional research director, and there are about 5 or 6 of us with a national lead, and Dendron's role has 2 roles, really. It's about delivery of research as well as encouraging people to do research, patients and researchers themselves. And it has a network of nurses and resources to engage with people with research. Now, recently there's a new thing they've set up called the RAFT, which I don't know what it stands for, but that basically is you can volunteer your details if you wanted to be contacted or involved in research in dementia and other neurodegenerative disorders, but particularly dementia, and then Dendron will keep you on a sort of list and contact you. So you sign a consent form, and that's a way of trying to fast-track people into these early studies that we want to do and that are being funded, and I'm involved with one with a drug called minocycline, which is another Department of Health. So I keep plugging the Department of Health. They are pouring money into innovation, but my worry is that it will possibly fail unless we get your engagement and help, because we need the patients and we need the people and we need the support. That's all I'm going to plug.
So if you're interested, just Google Dendron and take it from there. It's
all me. I'm very happy.
Google Chris. Derek.
I think what we've heard so much is that a diagnosis can be frightening. At the right time, it can actually help. It can help you get the care you need, the treatment you need. It can help you make the planning decisions you need in your life. It can prevent you missing the chance to do things that could give you that special period to adjust to the disease. It will be too late. So there's certainly diagnosis too late, and there's certainly diagnosis too early. And I think what we need to do is to come up with a consensus about what is the right time and how do we make that happen. Because frankly, we don't serve people very well at the moment in many parts of the UK. And I don't just mean there's some counties that are worse than others. I mean, just some GP practices, some memory services are serving patients better than others. And I do think there is scope to try and to have a bigger debate about what we want the dementia diagnosis and how that's joined up to care to work. And that is, I think, where we should be focused, rather than on the question about should we screen or not, which I think is a slightly it's a polarising point, because I don't think anybody at the moment is proposing in the UK screening people who don't have symptoms. I think that's, that's not what people are talking about now. But there's other sorts of meaning of screening, which are very much where we might want to discuss things, but maybe that word itself is not terribly constructive.
Thank you very much. You mentioned controversy and debate. Over the last few months, there's been a lot of polarised views, as you say, the sort of pro-screening lobby and the anti-screening lobby. But I've sensed over time things have been getting closer and closer. But I do think the controversy has been really good. The controversy has meant that we've had meetings like this. And meetings like this mean that we're talking about dementia. We're talking about it as a real condition which affects, in some way, just about everybody at some stage. It's going on out there. And through talking about it, making it easier to talk to your doctors, your friends, your neighbours about it, removing stigma, and we heard stigma mentioned a few times, is absolutely key, because there isn't a whole lot medically one can do with these kind of conditions. There's a bit, but so much of it is about, as Derek rightly said, it's about how you get the care, how you get the support, and how most of all other people interact with you in order to enable you to have a great life. This kind of controversy, I think, has been really helpful. Time is upon us. We're finishing now. I do hope you've had an interesting and enjoyable evening. I certainly have, and I'd have been happy to sit here a lot longer. I felt as we were just beginning to scratch the surface of this, and maybe we should be doing this again. Love to thank our fantastic panel for their expertise and experience. Really appreciate it, particularly Derek and Chris for giving their excellent 6-minute presentations. Really appreciate that. But especially I want to thank you, the audience, for coming along this evening and really making it a great evening. Thanks very much for your excellent contributions. You really made it fascinating and made it really roll. Please do keep in touch through the survey that I mentioned. Please give us your details if you can. You've been a fantastic audience, but now it's time to say good night. Thank you very much and have a safe journey home.